Okay, good afternoon. Good afternoon, everyone. I'm very pleased to introduce this webinar that will be focused on the pain management in the rehabilitation patient. The management of pain represents a very hot topic since many years. The very famous Hippocrates already stated divinum opus est sedare dolorem, while in recent years a very famous anesthesiologist, Professor John Bonica, who founded the International Association for the Study of Pain, wrote that the proper management of pain remains one of the most important and most pressing issues of society in general, and scientific community and health professions in particular. You see here, this is a photo of his book, the very famous book he published. The first edition, the edition was published in 1953. It's a book I took from the library of my director, Professor Massazza, who is attending this webinar. So thanks a lot to Professor Massazza for his participation. Well, I truly think this book, as well as many other pain publications, should stay on the desk of all physical medicine and rehabilitation residents for a daily consultation. Indeed, I think that the proper management of pain is an essential part of the daily practice of physical medicine and rehabilitation doctors. We are asked to manage every day patients presenting with acute or chronic pain. This topic, acute and chronic pain conditions in rehabilitation practice, is not only extremely relevant, it is also extremely wide. This is why I think we cannot cover this very wide field through a single webinar. We have decided to discuss today mainly several issues relative to the pharmacological management of chronic pain. And we have decided to ask the availability of a giant of this field to present this topic. I'm very pleased to introduce the lesson of Professor Anthony Dickinson. Professor Dickinson is from the Department of Pharmacology at the University College in London. He received his PhD at the National Institute for Medical Research in London and has held subsequent fellowships and postdoc positions in several countries, including France, US, California, Sweden. His research activity was mainly focused on the understanding, the transmission, and control of pain. Professor Dickinson was the first showing the role of NMDA receptor in persistent pain. He has authored more than 300 publications, including publications I reported here. He published in Nature and Science. So, Professor Dickinson, if it is okay for you, this presentation will be recorded. Thanks very much. Thanks a lot for your availability to participate. And I also want to thank Dr. Roberto Simeone for the availability of his company to support this didactic activity.
Great. Thank you. Thank you very much indeed for this invitation. It's a great honor. And I've always loved being in Italy, and at the moment I can't, but this is the next best thing. So I'm going to be talking about the pharmacological management of pain, many different types of pain. But the more general title, I think, is quite an important one, because what makes up the pain experience? What is it in our central and peripheral nervous systems that generates what each individual patient and each of us describes as our pain experience? And so what I would like to do is to go from the periphery through into the brain and spinal cord and talk about the mechanisms, but we can't really explain mechanisms particularly well in a patient. We can take a history, we can do an examination, but the pharmacological agents we have do have defined mechanisms of action. And so we can use pharmacology to work out mechanisms within patients. And I think that's an important aside as well. And so in this slide on the left, you see this long lost medieval approach to peripheral neuropathy. All you do is replace the leg and put a new one on. Well, we haven't got that technique anymore. But on the right, what we do know is a fair amount about signaling in the nervous system. And by altering signaling mechanisms, we can modulate pain. And so the way to think about pain is that it's an excess, it's too much activity in sensory pathways. And so overall, we have two possibilities. The first one, we try and block that excitability directly. The other approach is we try and increase inhibitions. We try and balance the excitability by inhibitory systems. And those are the two major mechanisms for controlling pain. And what I'd like to do is, as I said, to go from the periphery through to the higher centers of the nervous system, look at pain mechanisms and talk about management. And I think one of the really nice things about being in the field of pain is that we can go, and it's called translation, we can translate from preclinical science to patients, and equally we can translate from patients to preclinical science. If you think about other disorders of the nervous system, things like schizophrenia, anxiety, etc., it's extremely difficult to model those in the basic science, whereas pain is a universal experience. And so we can move from the laboratory to the clinical experience and back again. And I think pain has been very efficient at doing that. So just a disclaimer, I've spoken on behalf of these companies in the recent times, but because this is such an important lecture, I thought I'd better get some feedback. So I approached my grandchildren, and at the start, things were going very well. They seemed very interested. Maybe the bottle of wine helped. That wasn't for them. But then I tried the younger ones, and they thought it was actually quite a comical, humorous lecture. So we'll see what your reaction is as well. But pain starts out in the body, in the periphery generally. There are exceptions to this, and I'll talk about those as we go along. But the figure on the left is just looking at a peripheral pain sensing fiber. These would be C and A delta fibers. And the important point, of course, is that they have a cell body in the dorsal root ganglion, and they have a peripheral and a central ending. And if you look across here, it's incredibly complicated, and the details are not important. But basically, there are many different populations of peripheral sensory fibers. They have different markers and receptors on them, and this allows pain to be generated by so many different stimuli. So you can look at some of these, and the pain might arise from a chemical activation. In other cases, it's a different chemical. In other cases, it's too much cold or too much heat. The mystery, and it really is a big mystery, is that at the moment, we have no idea what the molecular entity, the molecular background for mechanical pain is. So we know all about chemical and thermal pain extremely well, but we haven't found the mechanical pain sensor, and that clearly could be very interesting. But with these multiple C fiber populations, what we have is a rationale for trying to block pain where it starts. And out of all disturbances of central nervous system processing, pain, of course, is the only one where you have an option of stopping pain where it starts in the periphery. It's experienced in the nervous system, but we can stop those messages getting in. So the first part of this talk will be talking about some of these peripheral fibers and how they respond to painful stimuli. But on the right, life gets even more complicated when we arrive within the spinal cord. And here, these peripheral populations of fibers, so the pain fibers, but also the touch and the proprioceptive fibers, converge onto spinal cord neurons. And in the periphery, everything is to do with excitation. We need to get that painful message in from the body into the nervous system. But once we're in the spinal cord and the brain, the second option for controlling pain arises. So some of these neurons contain GABA, the inhibitory transmitter. Others have opioid receptors on. And so once we're in the nervous system, we have the possibility of increasing inhibition as well as blocking excitation. We have more options. But let's start with the periphery. And it's extremely important because I think we sometimes forget what pain is. It's a sensory and an emotional response. The classical spinothalamic cortical pathways, that's the sensory component of pain. But equally, when we look at projections of the spinal cord into the brain, we have others to the limbic, to the emotional brain. And so this generates the fear, the aversion, the mood changes that pain causes. That's the affective component. We know that anxiety and psychosocial issues are incredibly important in chronic pain. And we know that without a peripheral input, the brain generally doesn't generate pain, but the brain is also able to interact with those inputs. So if we look at this simple diagram here, we have peripheral events, and generally speaking, they might be caused by tissue damage. So it could be a trauma. It could equally be surgery. It might be a disease or nerve damage. And these two are very different processes. The peripheral inputs when tissue is damaged are very different from those when nerves are damaged. But those inputs arrive in the spinal cord, and the spinal cord integrates that information and sends it on into the brain. And so, as I mentioned, these two parallel pathways, the cortex has this map of the body, and it allows us to locate our pain and rate it in terms of its intensity, the sensory aspects of pain. But equally important, our ancient emotional brain, the limbic brain, generates the fear and the unpleasantness of that stimulus. And so peripheral inputs, spinal cord activity, events in both parts of the brain, and also things like the context of the pain, memory, the coping mechanisms that some people have, they will generate the pain experience. But what's going on in the brain talks back to the spinal cord, and it's like traffic signals. So the limbic brain controls the brainstem, and then there are what are called descending controls, and they're like traffic signals, red for stop or green for go. And so what is going on in these higher centers of the brain is able to reduce, amplify what is happening at the spinal cord level as well. And that's the background for looking further into this pharmacology. So in the periphery, it's to do with channels and sensors and peripheral sensitization. In the spinal cord, there is something called wind-up, which is this amplification mechanism that generates what's called central sensitization. And both peripheral and central sensitization can be induced extremely rapidly. And then the brain controls the spinal cord. So that's another important issue. And then in the brain, we have all the comorbidities that pain generates that have such an impact on quality of life in a patient, and also reduces our reward pathways. And this is very interesting new research, but we need reward and motivation to do the things we enjoy in life. And if pain reduces reward, patients often find it very hard to do the things that normally gave them pleasure, because that motivation, that reward is missing. So let's just start off looking at different types of pain. And this is a very important area. So what we have here are nociceptive pain, the term that's used, caused by tissue damage. So it's generally an inflammatory response to a noxious stimulus. Tissue damage involves chemicals, so nociceptive pain is driven by chemicals. It could be trauma, it could be surgery, and osteoarthritis would be an example of a disease. But by contrast, neuropathic pain is initiated or caused by a lesion or a disease of the nervous system. So as it's nerve damage, it's changes in ion channels, not the chemicals that are there when tissue is damaged. A very, very different starter. But it's not that simple. Pains can coexist, so low back pain and cancer pain very often have both tissue and nerve damage, makes life more complicated. We have this term that's been recently produced, which I must admit is a very strange word, nociplastic pain, where there's no obvious tissue or nerve damage. So this might be something like fibromyalgia, which we have to look upon separately. But then up here, following surgery, post-surgical pains are very often neuropathic. And what's happened here is that the surgery damaged tissue. Tissue broadly heals, and so the nociceptive pain disappears. But if at the time of surgery there was damage to nerves, the persistent post-surgical pain is often a neuropathic pain. So it can change with time. But things again change. So this is osteoarthritis, and this has been looked upon as the prototypical, the hallmark nociceptive pain. And the idea, of course, you go from a healthy joint with cartilage that's damaged and eroded, so tissue damage, nociceptive pain. You can see central sensitization in these patients, but this is due to the peripheral inflammation. But interestingly and increasingly, a number of patients with neuropathic pain, they have pain on movement, spontaneous pain. They describe pain as if it's neuropathic, and they have a loss of function as well. And it's interesting to note that with inflammatory pains, if you remove the damaged tissue, so you do a joint replacement, you have a new hip or a new knee, the tissue damage is gone. But there are a number of patients who have new joints who still have pain, and they might be the ones with neuropathic pain. So just as an example of these changes, there's this study looking at persistent post-surgical pain after total knee replacement, it was quite marked. So depending on who'd done the surgery, so there might be issues of surgery and the type of joint, 16 to 39%, and neuropathic pain was seen in a significant proportion of these patients. And just looking at patients with knee or hip osteoarthritis and using this questionnaire called Pain Detect, which simply has a series of questions. It's been very well validated. It's got good sensitivity. We can see that 34% or 13 or 28, depending on whether it was hip and knee, and the neuropathic pain appeared to be more common with the knee. It's not just simply a nociceptive pain, and we might need to be thinking about treating some of these patients differently. And so they might have to be used with agents. They need to be treated with agents that are able to change ion channels. But let's start with classical nociceptive pain. And here we have an ongoing activation of a C fiber, so it's shown here, by chemicals. And it's been called the inflammatory soup because there are many, many chemicals generated in damaged tissue. Every cell in the body needs ATP for energy, but ATP as a pain receptor. So release of ATP from any sort of cell that's damaged can produce pain. Damaged tissue is acidic, and hydrogen ions generate pain as well. And we have no drugs to block these. What we do have are the prostaglandins here in red, and the non-steroidal anti-inflammatory drugs, the COX-2 inhibitors, that are able to block the production of these prostaglandins. And so the issue with tissue damage and these drugs is that generally we're interfering with one of the chemical mediators and leaving all the others, and which is why these agents can be useful, but generally with moderate to severe pain are insufficient. So at low doses, these chemicals will sensitize these peripheral endings, make them more responsive, and at higher levels will activate them and produce an ongoing pain. And I wanted to move to a beautiful example of this peripheral chemical activation, which is migraine. And I think it's interesting for a lot of reasons, and one of them because it makes the very important point that the periphery and the central nervous system work together. So the vasculature on the left, in the meninges, the pia, the membranes of the brain, is abnormal in a migraine. And this is due to a chemical called CGRP, which is released from trigeminal nerve fibers. It works on the vasculature, it causes vasodilatation, and it causes pain. But that is insufficient to cause a migraine because we also need changes within the central nervous system. Changes in the cortex and the thalamus, in the midbrain, in descending controls, and in the trigeminal complex. And of course, interesting points about migraine is that hunger, bright lights, sleep problems are triggers for sensitizing the nervous system. So a release of CGRP in the periphery, together with a central sensitization, produces the migraine. And it's one of the only pain areas where we can actually measure the chemical. So we can measure this in jugular blood, for example. And if you just look at this diagram on the right, a trigger is given, nitroglycerin. And as the migraine fully develops, you can measure elevated CGRP. And you can look at it in other tissues as well. And so these CGRP containing neurons respond to many stimuli that generate pain and unpleasant stimuli. And the huge breakthrough here has been to understand in B up here that this vascular and pain signaling effects of CGRP can be blocked by antibodies. And so at the bottom right, a large number of antibodies to CGRP, which bind to the chemical and stop it working on its receptor, have been shown to be highly effective in migraine. And so it's an unusual pain disorder in that, one, we can measure the chemical, and that's shown here again in A at the bottom, dramatic increases, and by preventing CGRP working on its receptor, we can have a very effective therapy. And so it's a combination of central and peripheral mechanisms, sensitization of the periphery, central sensitization, and the generation of migraine. And one of the arguments for this, and one of the very important points, is how is the nervous system and the periphery talking to each other? We don't know. So here is another factor. And the reason we're all here today is that we have nervous systems that have been connected and wired up properly. So this is a chemical called nerve growth factor. And as the name suggests, in fetal and early life, we need this to connect up our complete nervous system, whether it's our sensory nervous system or the central. The gene is switched off probably in humans at the age of about 21 or 22. That's when we think the nervous system is fully wired up. And incidentally, it's interesting why me, like many other teenagers, was a very difficult person. And the excuse for this is that until we're in our 20s, our nervous system is not fully connected. So it's not surprising, maybe. But the gene switches off. We don't need nerve growth factor anymore until we damage tissue. And now when we damage tissue, we have a release of NGF from non-neuronal cells. So it could be a bone or any damaged tissue. It doesn't really matter at all. There are effects on mast cells, on the autonomic nervous system, but also it binds to the peripheral endings of pain fibers. It generates hyperalgesia, and it's transported into the ganglion, into the cell body, where it has genomic effects and increases the production, and you can see CGRP here, more ion channels, etc. So direct genetic and indirect effects. Now, it's nerve growth factor as well. And so in this example, what we see is the innervation of a bone. In A, it's the normal innervation, but in B, a cancer is growing inside the bone. And the growing of that tumor generates release of NGF. And in addition to what you saw here, which is the direct sensitizing and activating effect of this molecule, what you also get is a hyper innervation of that bone. And this has been seen in animals with osteoarthritis. As the animal ages, NGF is produced. There's a hyper innervation as well. And so the same tactic that was used with CGRP was used here. Agents like this tanezumab, humanized antibodies versus NGF. If you have an antibody, they're highly specific and they're highly stable. So their duration of action is weeks. And drugs that were antibodies to NGF have been highly effective in osteoarthritic pain, in cancer pain to a limited extent. It's very hard to study patients with cancer, obviously, and in low back pain. There were weeks of very good pain control following a single injection. But in many of these patients, they needed premature joint replacement. And it wasn't just the patients with osteoarthritis, patients with low back pain had the same problem. So this has led to issues with this. Interestingly, the trials were stopped in the US because of this side effect. The patients demanded they were given the drug again because the pain control was so good. And at the moment, it's not clear whether this will prevent these drugs becoming therapy. But it's a very good example of blocking an important peripheral mediator can be highly effective. So let's move away from tissue damage and let's look at neuropathy. The peripheral processes are very different. As we've said, these are ion channel changes. And so when nerves are damaged, a number of things can happen that alter their functionality. And of course, at the top, we have the different peripheral nerve fibers, the large fibers for tactile and proprioceptive information, CNA delta fibers for pain. All of these peripheral nerves can be damaged, at least in theory. And if we have disconnection from the periphery, we have numbness, but those fibers might be still connected to the spinal cord and can give ectopic ongoing activity. So this is one of the main reasons why patients with diabetic neuropathy, for example, describe their pain as being ongoing, but they can't feel their foot. So they're numb, they're insensitive, but their foot is painful. Disconnection, no evoked activity, but ongoing activity. But with any fibers that are still connected to the periphery, evoked pains can be generated. And for example, allodynias, where touch and cooling, for example, are now painful. These allodynias generated in neuropathy are due to activity in still connected peripheral fibers, sensitizing the spinal cord. So in the case of peripheral nerves, key to anything is action potentials. And of course, that is sodium channels. So we all know that in certain circumstances, we could use lidocaine as a local anesthetic. We could use regional anesthesia. If we can get to the abnormal activity, we can block pain signals. But one of the problems here is that in neuropathy, the whole signaling of a peripheral nerve is altered. And the analogy that I've used for many years now, but I think it's quite a helpful one, is like driving a car. So we turn on the ignition and we need to move. And that's the sodium channels. They're the accelerators. They generate action potentials. So we move. We can brake and stop by opening potassium channels. So they will balance sodium channels. So we accelerate and we brake, but we have a transmission system. We have a gearbox, might be manual, might be automatic. And transmission system in nerves are calcium channels. So when we damage a peripheral nerve, there is an increase in function of sodium channels, a failure of potassium channels, the brakes, and an increase in transmitter release through calcium channels. And the proof of concept, of course, is that in neuropathic pain, lidocaine and carbamazepine working on sodium channels can be effective, and gabapentin and pregabalin that modulate calcium channels can also be useful. But these are generally given systemically and can have side effects. And the problem, of course, is that sodium channels are required in the autonomic nervous system, they're required in the brain, the cardiac system, etc. So we need to have a local administration. And then this guy, John Wood, who is at University College, where I am, was thinking about this and considered the fact that sodium channels, it would be quite surprising if every single one of them was the same. So we have to give lidocaine locally to limit its action to the sodium channels in the painful area. But what if we had more than one type of sodium channel? And he discovered 9, and this was in mouse, and humans have exactly the same 9 sodium channels. And very importantly, some of these have been involved in epilepsy in the central nervous system, for example. Some are in the cardiac system, but 1.7, 1.8, and 1.9 have rather selective localizations in pain signaling systems. So this would suggest that if we block these channels with a systemic drug, we should not have central and cardiac side effects because the channels are not involved in those functions. And before any drug was ever produced, we had this remarkable proof of concept whereby inherited pain disorders could sometimes be attributed to these channels 1.7 and 1.8. So a loss of function of 1.7, no pain. 2 different mutations of the channel, the protein is abnormal. And if the channel has a lower threshold or doesn't inactivate, you have a pain syndrome without tissue or nerve damage at all. And very interestingly, in patients with idiopathic neuropathy, about 10% of those patients have altered 1.7 and 1.8 channels. And just to show you one example, so one of the key ones is this inherited erythromyalgia, which is a reduced threshold of 1.7. But very recently, another one was described, whereby if you had the exact one single amino acid mutation, you had more pain. You were more likely to report pain than others. 0.4% of present-day Britons have this channel. You might say, well, that's very small. Sure, but many people have pain. But most importantly, this mutation historically appeared in Neanderthal pre-Homo sapiens. So this mutated sodium channel is still present in modern day humans, but it's an absolutely ancient one. And I think we'll see more and more of these. But here is a point about potassium channels and brakes. So it's a very busy slide. Don't worry about any of the details whatsoever. But this is a family where they have a gain of function, this inherited erythromelalgia. In red, the family's mother had only moderate pain. Her son had severe pain. Exactly the same mutation was present in their sodium channels. And then in this study, they took cells from the mother, looked to see what was different from her son, and what the mother had was that she had upregulated a potassium channel called the M current that has been shown to modulate pain in animals. So 2 members of the same family, one of them upregulates potassium channels and their pain from the altered sodium channel is gone. And looking again, a very recent study in labor pain, if you go through childbirth, not requiring epidurals or nitrous oxide or whatever, there's a chance it's caused by the fact that you have a enhanced potassium channel, a different one that produces less pain. So moving on to transmission, now we have calcium channels. And on the right-hand side here, we have the normal distribution of part of a calcium channel called the alpha-2 delta protein. And on the left, in the spinal cord here, this enormous upregulation. It's a little bit like sort of eyebrows on the surface. This one is trimmed and discrete. This one hugely increased by neuropathy. So it makes the point that transmitter release is hugely increased following nerve injury. And again, it's changes in ion channels. And gabapentin and pregabalin work on this subunit, and what they do is prevent the channel getting to the destination. It's like trying to drive to work and being stuck in poor traffic. You never get there, and those drugs stop the calcium channel getting to the right place. So this makes the point then that these peripheral channels, the sodium channels, the target for carbamazepine and lidocaine, and maybe some of these new drugs, sodium channel modulation, whereas centrally in the spinal cord, gabapentin and pregabalin modulate transmitter release. But it's very interesting that we understand the role of gabapentin and pregabalin in pain, particularly neuropathic pain. They work on abnormal neuropathic pain. They don't do really anything to normal acute pain, but we know nothing about how they work in epilepsy or indeed in anxiety. A complete mystery. Presumably it's the same action, but we don't know. But in pain, they're modulating transmitter release. So this kind of medieval hunt for the Holy Grail, how can we stop pain the best way? Well, obviously the periphery would be good, but if we have nociceptive pain, we have to use the non-steroidal drugs. And if it's neuropathic, we need to use lidocaine, gabapentin, working on sodium and calcium channels. We don't have drugs that work on potassium channels directly, although giving opioids indirectly opens them. So the point in the periphery, if it's chemical activation, we need the right drug. If it's ion channels, we need different drugs. And when we get in the central nervous system, things become a bit more common. And we'll look at that in a moment. But one very other important point is this fine line between pain and pleasure. And so at the top here, we have a number of ingredients that are used in food. We have the chili pepper, we have mint, garlic, horseradish, etc. At low levels, these are very pleasant, but we all know that too much chili is painful. Patients can rub it on as a local therapy. And the reason for this is that the chili pepper has got capsaicin in, activates and then desensitizes a sensor called TRPV1. And this is the human heat pain sensor. So capsaicin produces this burning pain through actions at this receptor. The TRPM8 is our cold receptor, and many patients with chemotherapy-induced neuropathy have cold hypersensitivity, and so menthol has been considered as a potential treatment for that. And then here we have TRPA1. Horseradish, cinnamon, garlic, very pleasant things in our food at low levels activate this, but too much activity, and interestingly, if you really annoy the police and they spray gas at you, it's painful because it activates TRPA1. And there's a human mutation of this that generates pain as well. So we have these additional sensors for heat pain, for cold pain, and for what's called irritant pain. So if we activate a peripheral fiber, we take a healthy individual, inject them with a low dose of capsaicin, activates the TRPV1 receptor, activates C and A delta fibers. And within minutes, that activation generates what's called hypersensitivity, central sensitization. And at the bottom right, this is the response of a neuron down here in the dorsal horn. Same peripheral input. The first stimulus produces a small response. 6 more, 12, 16. The course of several minutes, the neuron goes from signaling a small amount of pain to the brain to an enormous signal. So peripheral stimulation generates this, and it's seen in many, many patient groups. It's a common central mechanism. And these neurons, if they have a repeated painful input, exhibit what's called wind-up, and the psychophysical counterpart is temporal summation, so just a repeated heat or mechanical painful stimulus. Individual pain ratings increase, and what happens is that these sensitized neurons, sensitized by early painful inputs, now go into a state of excitability where touch, so brushing, dynamic allodynia, or punctate mechanical stimuli and cooling, gain access to pain signaling. And weak inputs that previously were too small to activate, it's too distant to activate the neuron, now are able to do that. So this is the basis for hyperalgesia, allodynia, ongoing pain, whereby these neurons have reduced thresholds, larger receptive fields, ongoing activity. And so this is a key central mechanism. And in terms of evolution, we're mammals, like many other things, but you can see central sensitization in invertebrates that live in the ocean. So way off mammals and humans, they show that repeated peripheral inputs into their primitive nervous system causes a sensitization. So at the top, we normally have pain and touch, different fibers are distinct. When we have central sensitization, large fiber inputs gain access to pain pathways, and we have allodynias. And this is seen, and this is just a list, whether it's visceral pains, CRPS, inflammatory pains, post-surgical, neuropathic, central sensitization, very strong evidence. And this is just one example. And if you just look at the time course of this, these central sensitizing events are important over minutes. So they're important in acute pain. And as you can see from these disorders, they're important in persistent pain as well. And so the stimulus number versus the response, much greater exaggerated wind up in patients, and also in the patients with knee osteoarthritis, this spread of pain, these increased receptive fields running out down towards the feet. And so this is not a sign of neuropathy at all or anything, it's a sensitizing effect. But there are some interesting issues here. These neurons in the spinal cord have inputs, let's say, from deep tissue. So this example of patients with osteoarthritis, joint inputs arrive, and the neurons also have cutaneous inputs. So if we sensitize these spinal neurons, their responses to cutaneous stimuli increase as well. And this is behind what's called referred pain, where you have an area of sensitivity around that original deep area of damage. If you look at the top left, just down here in C, this is the impact of central sensitization. Red is what the periphery told the spinal cord. Blue is the message the brain got. So it's like some low hills here. It's like the Alps here. And this is important because this is a central spinal cord mechanism. So if you have a patient and you do a scan or an MRI or an X-ray or whatever, see very small degree of peripheral damage, but they're giving you a very high pain rating, we can attribute this to sensitization of the periphery and here in the spinal cord. And ketamine is able to block this receptor for glutamate, the so-called NMDA receptor, and can be a very effective analgesic. But the NMDA receptor is required for memory, for cognition, for vigilance, etc. And so that's why we have the side effects of this drug. But interestingly, it's used reasonably frequently during anesthesia because the side effects don't matter. And so the surgical induced central sensitization can be blocked by a drug such as ketamine. So that's excitations. What about inhibitions? These are very, very important. And there's another beautiful example of this inherited disorder, so-called human hyperexplexia, very hard to say. It's a mutation of the glycine receptor. And glycine neurons are in the spinal cord. They're mostly concerned with motor reflexes, but there's a few of them in the sensory dorsal horn. And in this mutation, glycine doesn't operate, and the individuals with this inherited disorder have enhanced responses to heat, to cold, to pressure, and abnormal withdrawal reflexes. So a simple, in this case, congenital loss of an inhibitory transmitter can dramatically change responses to pain. And another very important inhibitory system is that produced by opioids. So here we have the spinal cord. We have our C fiber inputs arriving on a spinal cord neuron that projects to the brain. And there are opioid receptors on the terminals of pain fibers. So they inhibit transmitter release, such as glutamate, from the pain fibers. The large fibers don't have those receptors on, so tactile information is unaltered. Most of the opioid receptors are presynaptic, but there are some others on spinal cord neurons and they inhibit those. And of course, you can deliver opioids directly to this site by epidural or intrathecal administration. If you give an opioid systemically, you interact with descending controls as well. So this is a very powerful control, a direct spinal and a supraspinal control of sensory information. But of course, we all know that opioid receptors generate other things, side effects, ranging from respiratory depression, cough suppression, constipation in the periphery, nausea and vomiting, etc. And so their use is limited by these side effects. So I realize it's just about coming up to an hour, and this is a little overview, which you're very welcome to have a look at. And I suggest we perhaps take a 5-minute break. Would that be okay? And I'll start again in 5 more minutes. So this is just an overview of what we've seen. You can just have a short read. So see you in 5 minutes. These events we've looked at in. Let's move into the brain. And one of the big advantages in recent years is the ability to do imaging of the human brain. And so this is a very interesting composite of 2 scans, one group A, one group B. And this is just looking at connectivity. So there's no applied stimuli. It's simply looking at conversations that are going on in the brain. And in A, you can see the midbrain here is active. In B, an enormous ongoing conversation between many areas of the cortex and the midbrain. So the question, and this is just a lecture, it's not an exam, who are the patients in pain? And we'd all say B, obviously. And the answer is nobody at all. But what's happening here is that A are a group of individuals, no pain, there's no stimulus. B, no pain at all, but these are individuals who suffer from migraine. And even in the absence of migraine attack, what's going on in the brain is a very, very different set of interactions between these areas. And the importance of this midbrain is that it's the source of descending controls. So what we have here are painful inputs into the areas like the amygdala, the cingulate cortex, the emotional brain, generate and interfere with normal function, and the changes in mood, fear, anxiety, the sleep-wake cycle, all these comorbidities of pain result from pain interfering with normal function in these areas. And then these emotional parts of the brain project to these three anatomical areas that are moving further and further down the brainstem until they generate pathways back to the spinal cord. So a number of important points to be made here. Some of these neurons, off cells, reduce pain. Others enhance it. And generally speaking, the inhibitory pathway is through noradrenaline, acting on its alpha-2 adrenoceptor, whereas much of the descending excitation is 5-hydroxytryptamine serotonin through its descending controls. Another very important point is that these descending pathways are not anatomically conserved. They will, for example, innervate the whole of the spinal cord and trigeminal complex. And so one could propose that abnormalities in central processing and modulation could lead to mood disorders, sleep problems, sensitivity to other stimuli, and widespread pain states. So this could be some of the circuits that are abnormal in fibromyalgia and in irritable bowel syndromes. If we image the human brain, we can see exactly these same areas. We can be confident that these pathways are important in human pain modulation as well. And for example, we look at the human brain, these locus coeruleus pathways to the spinal cord are very pronounced. So this could well be the descending inhibitory pathway. So it's not surprising, perhaps, with these painful inputs into this emotional brain, that all these comorbidities, and these are, look, moderate to very severe problems of depression, anxiety, lack of energy, sleep problems, it's pain messing up our limbic brain. And very importantly, and this was this new work I've just mentioned, these areas like the anterior cingulate, the prefrontal cortex, the amygdala, they project onto pathways to do with reward and motivation. The nucleus accumbens, this ventral tegmental area. And there's very good work from Frank Pareca in the States now, preclinically, showing that pain disrupts reward and pain relief is rewarding through these circuits. So maybe not only do patients have problems of emotions, of sleep, but as I mentioned, motivation. And so the things that are normally pleasant in their lives are no longer so. So these descending pathways, and I mentioned the fact opioids can interact with them, use noradrenaline and 5-HT. And of course, we know that antidepressants can be useful for neuropathic pain. They block the uptake of these transmitters, they increase synaptic levels. And when you look at the ability of antidepressants to work in patients, the ones with a noradrenaline component, like amitriptyline, the tricyclic drugs, the serotonin noradrenaline, they're much better than the selective serotonin. And that's because noradrenaline appears to be the major stop inhibitory signal. So are these important in humans? Absolutely. And one of the absolute sort of key points I think we all need to be very sure about is that psychology and neurobiology are the same thing. They're not separate functions of the brain. And this is a very nice example. You give volunteers a placebo, you image their spinal cord and brain, and placebo switches on a descending inhibitory pathway. You can do the opposite and you produce a nocebo. So now expectation produces hyperalgesia. You see a descending excitation. So these descending pathways can be switched on and off by expectation, psychological events. So what we have is descending inhibition through noradrenaline protects us against pain. 5-HT can promote. Normally there's a balance, the two are equal, but it's like those kind of American police films where there's always like two policemen, one of them is good cop and one is bad cop. Noradrenaline's the good cop, inhibiting pain, protecting us. 5-HT enhances pain through its two excitatory receptors, the 5-HT2 and 3. And so in persistent pains, we lose this descending inhibitory pathway, and the brain is now further enhancing pain. So this was a sort of premise, but these pathways, shown here, as I mentioned, something going wrong in the limbic brain has the ability to enhance spinal cord sensitivity. And this recent imaging study in patients with fibromyalgia looked at the cortical control of exactly those brainstem areas you've been seeing. And in a normal state, the brain is in a pain inhibition mode. In fibromyalgia, pain facilitation. And so descending facilitations from the brain produce a generalized global sensitivity. But we can actually measure this descending inhibitory pathway. And in animals, it's called diffuse noxious inhibitory controls, which is a neuronal event. In humans, it's called conditioned pain modulation. This is a picture from medieval France. Nobody understands it, but it's two sisters. And one of them was thought to be expecting a child. So maybe one on the right was in labor, and her kind sister applied a second painful stimulus. And this is a more recent version from London. But the point is, one pain should inhibit another. This is present in about 90% of the normal population, and one pain will inhibit another by about 30%. If you look at pain versus pain in fibromyalgia, it's gone. Osteoarthritis, peripheral neuropathy. And very importantly, if you just look at this table, chronic and acute pain are major risk factors for what? These are patients going to have surgery. And if their descending inhibition is weak and they have high levels of acute pain, irrespective of surgery, gender, age, or whatever, they are high risk for persistent post-surgical pain. So we can measure these in humans, and it's generally done very simply. You might have heat on the hand versus cold pain on the foot, or any combination. And this is just a list of many pain conditions where these descending inhibitions fail. One pain is no longer able to inhibit a second one. And you can see it's very, very prevalent in many pain conditions. And these descending inhibitions, this noradrenaline inhibition, is controlled by the cingulate cortex, the prefrontal cortex, the amygdala, areas to do with aversion, fear, emotional states, and we can start to understand how the effective components of pain are able to possibly enhance pain, the sensory component, by switching off these inhibitions. But most importantly, and this is the sort of the last points to be made in this lecture, and then we can have a discussion. But if this is a descending inhibitory system, what about drugs that work on noradrenaline? And this looks at two agents, duloxetine, the antidepressant, the serotonin noradrenaline reuptake inhibitor, and this drug tapentadol with some mu opioid actions and also noradrenaline reuptake. On the left, duloxetine. If one pain inhibits another, so on the left of this scale, one pain inhibits the other, duloxetine has minimal efficacy. It's going to elevate noradrenaline. If your descending inhibition is working, the drug has no effect. The system's operating. But to the right, all these patients where the second painful stimulus made pain worse, so this is probably a descending facilitation, these had high efficacy of duloxetine. And on the right, in blue, the reduced descending inhibition seen, and these are both patients with diabetic neuropathy, is enhanced and restored by tapentadol. So this is a beautiful example of what's been called precision or personalized medicine, where you can measure the activity of these descending controls, give a drug that works on the pharmacology of those systems, and see efficacy. And the importance of these descending pathways coupled with spinal cord sensitization is that in a study here of about 400 patients, they all had chronic non-malignant pain, just mixed pains. 69% of these patients had altered sensitization of the spinal cord or altered descending inhibitions. And the worst condition you could be in is to have increased sensitization and decreased descending inhibition. And your pain was worse, the pain areas were greater, etc. So that was just one example, and a beautiful example of precision medicine in a way. But this is something maybe more amenable to other generalized approach to pain. It's not, doesn't require testing descending inhibitions. This is looking at patients with neuropathic pain, a huge number. It was a German study. The patients had all sorts of different etiologies, but when you pull them together, having carried out some highly specialized quantitative sensory testing, so looking at thresholds to cold and warm and heat and mechanical stimuli, looking at allodynia, etc., looking at wind-up, there were three subgroups of patients. Statistically, they were different from each other based on their sensory profile. This has also been seen in fibromyalgia and in patients with persistent pain following surgery to the hernia. So here's a really interesting principle now. If patients, independent of their etiology, have different sensory profiles, one, these patients can't all be the same, and two, those different sensory profiles suggest that they have different mechanisms going on. So what might this tell us? Here, at the top right, if you look at the number needed to treat for neuropathic pain, it's highly variable. And it's actually got worse over time. That's another question altogether. But the point is, the drugs for neuropathic pain in these trials, which are all based on a single etiology, don't work in all the patients, and maybe on average work in 1 in 4. But if you pick the right drug, it works, but it might not work in somebody else. So if we have different sensory mechanisms going on based on the different sensory profiles, maybe we can match a particular drug to a particular profile. Preclinically, if you look at this on this vertical scale, about 15 different drugs tested on sensory processing in spinal cord and brain of animals, looking at neuronal activity, they have a very different profile on brush versus noxious, mechanical, heat, cold, spontaneous activity. Pharmacologically, they're different from each other. And here is a beautiful example of the human counterpart. This drug, oxcarbazepine, which is a sodium channel blocker, is used in trigeminal neuralgia, but in Northern Europe is widely prescribed by primary care doctors for any neuropathy. But all the trials have been negative, apart from trigeminal neuralgia. So the question was, why are these GPs prescribing this drug when it doesn't work? What's the point of that? And on the left, you just look at the top here in A, it doesn't work. It's no better than placebo. But on the right, if you subdivide your patients and you do it in a very simple way, you ask them, do you have ongoing pain? Or is your pain worse when you have an applied stimulus, cooling or brush or something like that? And the ones where there's hypersensitivity, called the irritable nociceptor, this rather strange term, now the drug works really well. So this has been the first example of subdividing patients and showing efficacy in some patients and not others. And you saw something similar with the noradrenaline drugs and descending controls as well. So let's just go back to those sodium channels. 1.7 and 1.8, these should be beautiful targets for pain. We have the inherited channelopathies that tell us how important they are, but then a study on a drug that's a 1.7 blocker, and it was compared to pregabalin, and it was ineffective completely. A sodium channel blocker of 1.7. But, as they say in the discussion, they never investigated whether nerve hypersensitivity would be an issue. And for oxcarbazepine, it was critical. And worse, they said, well, we looked at one etiology and they only had ongoing pain. So this new drug, which must have cost millions and millions of euros to develop, when it went into the trial, the presumption was it would work in everybody, and it didn't. And so this has got huge implications for the future. And one of the things we might have to be doing is to have a baseline profile of a patient, their sensory profile. You could look at quantitative sensory testing or pain against pain. And incidentally, simple bedside versions of QST have been reported this year, as have simple ways of looking at descending inhibition too. So what you could do is have a profile. You then randomize and you look at the effect of a drug in subgroups and look at symptoms rather than everybody being the same. And this is very, very important because it could be just like this novel drug that failed to beat placebo, that many, many drugs have failed in trials because the presumption was every patient was the same, and yet they might not be. So this is this pharmacology that we've talked about, where these drugs are working. And the one pain I haven't mentioned at all is post-stroke pain. And here the issue is the lesion is somewhere up here, probably in thalamic pathways. And the problem is we have no idea what the pharmacology is of that lesioned area, whether we should be blocking excitation, increasing inhibition. And post-stroke pain is the worst example of a pain where we have little understanding. It's clearly deafferentation pain somewhere in the central nervous system. The pharmacology is unknown. So this is just a simple overview that pains are a combination of peripheral events. They might be chemical, they might be electrical. Blocking inputs makes sense, but we have to do that selectively. Central changes alter pain and produce comorbidities. We can restore normal central modulation, increasing inhibitions or reducing excitations. So I'd like just to sort of thank my research team for their input. Normally I'd say I'd like to thank them for allowing me to come to Italy and talk to you, but clearly I'm behind a computer. But the important point is the research we're doing hopefully is going to be useful for everybody. And now I'm very, very happy to answer any questions you might have, whether it's related to this or other issues that have come up. So thank you very much.